All right, welcome everyone. Thanks for joining us in our conversation on value-based care as part of the health track at Boise Startup Week. I'm Chris Hoyd, Director of Product at Vinyl, a product development firm that works with clients in the healthcare industry. And I'm joined today by Jenny Gudapati, Matt Bell, Robert Tierney, and Eric Foster. Thank you all for being here. Can you each take a brief moment to introduce yourselves to our Startup Week audience? And maybe Jenny, I'll start with you.
Sure. Hi, I'm Jenny Gudapati, Value-Based Healthcare Program Director at Boise State University. I'm a nurse by trade and have really gotten into teaching about healthcare reform, especially in moving towards patient-centered care. Really excited to be here today. So thanks so much for this opportunity, Chris.
Awesome. Thanks, Jenny. And Matt?
Sure. Hi, everybody. I'm Matt Bell. I'm the Vice President and Idaho Regional Director for Pacific Source Health Plans. Been with Pacific Source for a couple of years and been in and around provider side of healthcare in Idaho and Utah for the past 20 or so years. I'm glad to be here.
Very cool. Thanks, Matt. Robert?
Yes, I'm Robert Tierney, partner with Compass Benefit Advisors. We work with employers in the Valley that not only purchase health plans, but then are also self-funded employers. So we work with a gamut and really are focused on customer service and making sure that the employees are served and the employer gets the biggest bang out of their benefit dollar, because it's usually the second largest item on a P&L if you're in the service industry.
Excellent. Thank you, Robert. And last but not least, Eric.
Hey, Eric Foster, Senior Director of Health and Welfare Benefits at Albertsons. I've kind of split my career between being the benefits guy with a few very large national retailers and a little bit more time consulting with a variety of organizations that try to help employers do exactly what Robert mentioned, getting the most out of our benefits spend and having attractive offerings so that we're bringing in the best talent to take great care of our customers.
Awesome. Thank you all again so much for joining me today. I think we're ready to get started. Now, since value-based care is kind of a relatively new concept and also a fairly complex one, Jenny is going to kick us off with a primer on what exactly this idea of value-based care is. So I will throw it over to her. She'll share some slides.
So value-based healthcare, what is it and what does it have to do with business? So value-based healthcare, typically when I present on the value-based 101, I start with kind of a story in which we define kind of a typical dealing for business, where we would look at a Yelp review. We would look at patient satisfaction over another long period of time. But as I was preparing the presentation today, I decided that what I have learned is, unlike healthcare professionals, people in business have a tendency to understand and grasp the concept a little bit easier. So what I did today is, here is a picture of my whiteboard. When I first started putting together value-based healthcare at Boise State, we had a business leader coming to the university and wanted to learn about value-based healthcare and what it is. He was also bringing along a scientist and a research professor, because they were really trying to work on some wicked problems defining healthcare. So Tim Dunnigan, the dean, gave me about 5 minutes to prepare. So in 5 minutes, I whipped up my whiteboard, and believe it or not, this quick snapshot has been one of my go-to slides in understanding population health and value-based healthcare. So really, when you look at it, it can be broken down into some pretty simple thought processes. Value-based with healthcare and in any other industry is really increasing quality while decreasing cost. When you look at typical patient populations, in the past, healthcare has always defined our patients by what diagnosis they have. Are we a diabetic patient? Do you have congestive heart failure? But when you really look at driving patient outcomes and decreasing cost, it all goes down to risk allocation, and how can we best lower the risk of our patients and really drive them to have better health outcomes? Well, that is really primarily due to how we deliver healthcare. We need to increase patient access, and sometimes now more than ever, we have technology available to make care delivery options different than they've been in the past. Another huge focus for value-based healthcare is really moving from the traditional inpatient hospital type care where you're going to go to the hospital. Sometimes you would be there for 3 or 4 days instead of really looking at what can we done in the outpatient setting. Most patients prefer to be in the comfort of their home, and what can we really do to look at, once again, bringing the best patient outcomes through healthcare delivery. This goes into innovative payer models, and in the past, everything was fee for service. There's probably not a single person listening today that has not received one of those explanation of benefits in the mail from their insurance provider. When I look at my explanation of benefits as a nurse, I sometimes get confused because I've had procedures where the list of every single charge that has come to me has been 4 or 5 pages long. If I can't make it out, I am pretty sure that the majority of people not in the healthcare industry can't understand either. What if we could simplify healthcare into really making it about producing our best patient outcomes while being more transparent in pricing? So when you think about the health status of America, how are we doing? Right now, when you look at a total per capita healthcare spend, well, at least in 2018, this was the most recent data I could find. In the US, we spend about $10,600 per patient per year in healthcare. So you would think, since the United States spends the most per patient, that we would have really good results. Interestingly enough, that is not the case. UK is number 1, and the US primarily produces what you will soon learn to be pretty mediocre results. According to the World Health Organization, the US ranks 34th in overall patient care delivery. The other thing is, with our high expenditures, Medicare is unsustainable. It is forecasted that it will be depleted by funds by 2026. And our current fee-for-service payment system is largely responsible. We incentivize physicians and hospitals to provide as many services as possible. Every line item that you get on that explanation of benefits is, in fact, a cost incurred by that we must pay for. And there's very little incentivization to maximize quality or contain that cost for providers. So it's really turning this around to rethink and relook at how is healthcare best delivered. So the key principles of payment reform are pretty easy. The goal is to drive a shift towards shared risk and population-based payment models that incentivize improvements in the outcomes, quality, and efficiency of patient-centered care. I'm going to give you a quick overview and framework of the national goals, and hopefully as a community here in the Treasure Valley, especially as business leaders, we can move towards those national goals. This is just a continuum, right? Where we are, that category 1 is the old school fee for service. You go into the doctor, you get an x-ray, they write down a billing code, you get charged for that billing code for an x-ray. As we move through the spectrum, we start looking at alternative payment models, some of which are like a global payment model where there is a year-long payment. And if, as a provider, you can care for those patients within that amount of money, based on if you spend a little bit more than you're expected to, you may lose a little money for not being able to stay within that capitation. Or if you're able to care for your patients at a little bit less than what was expected, you can make a much larger profit. So how are these nationwide goals and where are we at? To look at the actual national land goals, by 2025, we are hoping as a country that in our Medicare Advantage programs to at least be at 100% in value-based healthcare programs. 50% for Medicaid, and 50% for commercial. So we have a long way to go to get there. And hopefully today, after listening to this expert panel, you're going to hear a little bit more and have a better understanding and realize how we can do this together. Because at the end of the day, it's all about determining value. Really looking at that desired change in patient outcomes, making our patients' health better, and dividing that by the total cost needed to achieve that needed change. Really easy definition of value, but it has been very difficult within the healthcare industry to really come to concepts and having to change the way we do things to deliver value-based healthcare. Here's my contact information. If I could answer any questions, feel free to reach out to me at any time. And that is probably the quickest definition of value-based healthcare that I have ever given. But I am really excited at the expertise of this panel, and I know you're going to want to listen to them as much, if not more, than me. So I'm going to turn it back over to Chris and get started.
Okay, so we just, covered a pretty complex topic. So I'm hoping now to kind of give our audience a little context into the perspectives that each of our panelists is bringing to value-based care. So maybe starting with Robert, can you talk a little bit about how the concept of value-based care factors into your current position?
Yeah. For smaller groups, not the size that Eric works with, but for some of the smaller groups, you're really looking for partners in carriers that provide some type of narrow network. The concept of managed care in the past got a bad name because it was always thought that the insurance companies were making decisions, healthcare decisions based on economics. Well, now kind of the shift has been, we really want the primary care provider to be making those decisions and really to be your guide through the healthcare system. Like Jenny said, it's a complicated system, delivery system. And for those who are self-directed, just going out and saying, oh, my knee hurts, I'm going to go to an orthopedic. Well, if you went to a primary care physician instead, they might tell you, oh, let's try to lose a little bit of weight first. And maybe that's the right solution and not going underneath the scalpel. If my only tool in my toolbox is a hammer, I'm going to use a hammer to fix everything. And if you ask my wife, a hammer and duct tape is usually what it takes for me to fix something. But that's from an employer standpoint, that's kind of what you're looking for. I'm in a unique situation where I work with some employers that are also providers, and we drink our own Kool-Aid, so to speak. We do have these value-based models or provider-directed care requirements within our own plans. And we have seen a dramatic decrease in cost. And that's not the only goal, because we also want to improve quality of care. And we've seen better care quality better outcomes when we have a PCP leading the charge and directing the care of the patient.
Okay, excellent. Thank you. You mentioned Eric has another perspective coming from, bigger companies. Eric, can you maybe touch on that?
Sure. The challenge for large distributed workforces is you've got one poor guy or gal sitting in a corporate office with their team trying to figure out how to distribute healthcare to, in our case, hundreds of thousands of people in dozens of states. But healthcare is local. So solving for each market where I've got dozens of colleagues that work in that market serving their community, there's not very many benefits departments that have the resources to try to solve that issue in each community. So you're largely beholden to what that community looks like, the providers involved, the facilities that are involved, and then you're really working through your wholesaler, which is an insurance company that for a large company like us, we're self-funded, right? But when people say the insurance company, they're thinking about a Blue Cross Blue Shield, a United, an Aetna, a PacifiSource. We're thinking it's us because we're the ones ultimately stroking the check, right? We're not paying premiums to anyone. We're funding every single dollar, and trying to do that in the aggregate when every market has its own ecosystem and behaviors, and every patient has their own particular conditions. And even then, value-based care is the idea of having optimal solutions for a million little scenarios that creates a crazy challenge. So even in places where I've got 1,000, 2,000 people, because I've got nice density, maybe there's a big warehouse there or one of the corporate locations, I can probably take the time to talk with that hospital system, that health system, and communicate what our goals look like and how we really expect our patients to be served so that they can be productive members of their community, their homes, and their workplace. It is great. And I might be able to have productive conversations in Boise or in Phoenix or in Pleasanton, but store 1, 2, 3, 4 in this town with 80 people, and I can't really influence how many heads are in beds in the hospital system, or identify really good providers versus bad providers and steer around it. It creates for lots of challenge, lots of complexity, and hopefully some job security.
Interesting. Okay, Matt, can you maybe touch on how it factors into your position?
Sure. Eric used a term that I actually had never really thought about as it relates to an insurance carrier, but the wholesaler of healthcare, and that is really kind of the role that we play. If I think about the 550,000 lives that Pacific Source covers or insures throughout a 4-state area, we're working with the provider community across that 4-state area to look at how do we improve the health of the population at large for those 500,000 people. And I view it, almost, our chief medical officer uses this analogy where we're trying to take healthcare from, he uses the analogy of an auto repair shop, where we're trying to look at fleet management and prevention as opposed to repairing each individual, problem with the car. And if you apply that to our members and to patients, we're better off when we look at and provide things like preventative care, preventative screenings, healthy behavioral change, as opposed to taking care of somebody who has high blood pressure and just had a heart attack. And so looking at it from that perspective is a much better way to view that. And from an insurance carrier's perspective, our ability to work with the provider community, whether it's large integrated health systems like St. Luke's and St. Alphonsus here in Boise, or Legacy Health in Portland, Billings Clinic over in Montana, they're just, it's easier to have a conversation when we're talking about 100,000, 200,000, 500,000 lives and how to better care for those patients in aggregate, as opposed to we have this one patient that had a heart attack and what are we going to do for that one patient? Not saying that that's not important, but the further upstream we can get, the better off we all are.
Awesome. Okay, thank you. So we've been, speaking, I think, very much sort of in the abstract so far about what this concept is and how it's sort of new for the healthcare system and what sort of needs to change for it to really get embraced. Maybe kicking it back to Eric, can we talk a little bit more concretely about things you've done in your experience to help advance value-based care? Yeah.
I think the challenge of trying to nail this down for every condition, even every heart attack patient, is really, really tricky. So for folks in my chair, you spend a lot of time saying, okay, where do I focus my energy? And in a for-profit organization, you're generally going to say, what are the things that are generating the most costs? And what opportunity do I have to get to, I used the word before, like an optimal setup, right? The problem is certain things have this huge variability in outcomes, right? You could have a knee replacement and feel like you're 20 years younger and get to do lots of stuff that you had too much pain or a mobility issue that you couldn't do. Or you could make yourself worse. I mean, the example we frequently use is back surgery. You could be substantially more mobile, or if that does not go the way you want, you could be deeply handicapped for the rest of your life. That type of stake is incredibly high. So for a buyer of healthcare, you really want to try to normalize that as much as you possibly can. And that's the quality piece of the equation. Can I identify a certain number of providers that the likelihood of a great outcome is so high if I don't do everything in my power to help the patients that I'm providing access to healthcare for get to that provider and remove as many barriers as I possibly can. Not only maybe I be hurting the bottom line of my health plan, but that person may be harmed in their ability to do their job, support their family, support our customers, right? And as an employer, and again, sitting kind of in the human resources function, that's the job. So yes, data helps you do that and identify where there are great providers that do that same procedure hundreds or thousands of times. And publicly or sometimes privately available data helps you stratify who's great. And people in our chair have the ability to build programs around that idea, or in Matt's position, to be able to help their clients see that if you want to get really broad and give everybody all kinds of choice, you can. But the cost for choice is normally money. If you want to try to constrain cost, you can constrain choice, steer people to places where you're going to get great outcomes. And then you're trying to find the subset of those great providers that are willing to say, yeah, I do that procedure, that real episode of care twice before breakfast. I know what my operating cost looks like. I know what my margins look like. You put a box around this episode and I will give it to you for this much money every time. And here are the outcomes that I guarantee. It gets more granular. It's not all my healthcare expense. It's not even all surgical expense. It's here's this episode for a patient that meets these criteria for this outcome. But there are providers out there who are very willing to do business that way. And for a large employer, it's a little easier, or for a health plan that has the aggregate member count, that they can provide that, where an employer might say, and I've done this in my current role as well as my last one, look, if you're willing to take us up on that, I will not charge you a deductible or a co-insurance to the degree that IRS law will allow us in whatever plan you're in. And I'm also going to pay to get you there, right? If you're an associate of ours in a rural part of the country and I might have to fly you 3 or 4 states away to get great care, I'll pay the airline ticket. I will get you from your front door to the airport. We will pay for every nickel of the thing because, one, I need you to be able to serve our folks. But one of the things we don't talk about as much is if I can decrease the likelihood of complications and revisions and all the other care that happens when a bad surgery happens, the plan saves substantially more money than the extra expense to get the horse to the water, if you don't mind the expression. So that's something in terms of like bundled payments or centers of excellence or some of these other buzzwords that employers are using to great effect. And when done well and managed well, your associates that make use of that, or their spouses, or in some cases their kids, once they get a really great outcome and they see how much the employer did in the favor of those folks to get those great outcomes, you get raving fans, you get some word of mouth, and at some point you start to standardize it. Large employers have been doing this for more than a decade pretty effectively, and a lot of other folks are saying, okay, now the proof's in the pudding and you're able to tell a great story. How do we get on board? And I think for most people that have done this, we're in favor of many other payers using this same device, because it's the old, as the tide rises of quality, everybody gets a better reference point on what I should expect and how much I should pay.
Super interesting. Okay, so Matt and Robert, Eric's coming from a place where he's maybe been able to try to find value at scale, and maybe with some resources that smaller companies wouldn't have. How would you say that the game is different for startups or smaller companies?
Yeah, I think Matt has more scale than most of my employees, so we go to Matt for some advantages from that scale. So for our smaller employers, and even the ones that are self-funded, where we're seeing success is working with wholesalers or insurance companies that that value population management, that are looking at the whole population, like Matt said, that are trying to keep the whole fleet up and running and in good shape. With translating it down to an employer size, you want to work with a company that has programs in place that keep your healthy people healthy. what a concept, spend money where people are healthy to keep them there. And then two, find a company that is working with those in your population that do have chronic conditions that have what I call concierge service. Someone else may call it care management, someone may call it something else, but really when you're talking to an employee across the table, somebody who's managing diabetes, and you put them in touch with this person who is a nurse and understands the healthcare delivery system and says, okay, if you check in, if you do the A, B, C, we know that you're going to have a better outcome than if you don't. And you put someone in front of these patients that are managing these chronic conditions to help them, like a coach, like a concierge service, then that will help overall. Now, for smaller employers who are buying an insured product, that may not mean a reduction in premium. More than likely it doesn't, because you're being rated with the whole population. But what it does do is it gives your employees, which is why you provide insurance, a better experience. It helps your employees that are healthy stay healthy. It helps your employees with chronic conditions stay out of the emergency room. And overall, that's what you want with your health plan, is you want to be able to provide a great benefit for your employees that they see value in, and that keeps them coming back to work so they can take care of your customers.
And I think I would add to what both Eric and Robert have said. From our perspective as an insurance carrier, we're able to take maybe some of those lessons that a super large self-insured group like an Albertsons has learned on their own patient population or member population, and apply those types of kind of best practices and make them available to a small group, a 15, a 20, a 25 member group, so that, I'm assuming that here at Boise Startup Week, we've got a lot of employers that are 10, 15, 20 member groups and small offices. But, if you go out to the exchange, Your Health Idaho, and look at the small group offerings on Your Health Idaho, each of the carriers that are on that exchange have programs that we've learned are positive and positively impact the health of the population, because employers like an Albertsons or like a Lowe's or a Home Depot or a Boeing has put in place in their large groups, and we've put in place for our large groups, and we can apply those types of things. It doesn't, and I guess the other thing that I would add to that is one of our larger lines of business is the Medicare Advantage world, where we're working with the federal government and applying lessons learned at the single largest population of insured lives, which is Medicare, and applying those same lessons and those same quality expectations to the individual and the small group line of business, where a 20-member group has access to things that they probably 5-10 years ago didn't even know they needed, and it really improves the outcomes for those members.
Awesome. Okay, thanks, guys. I'll now ask kind of an open question. Maybe I'll direct it to Jenny to start, but then we can just have kind of a conversation here on the panel. So Jenny, what do healthcare industry leaders need to do now to develop the types of partnerships that will move the industry forward into the shift for value-based care?
Sure. That's a great question, Chris. And I think everybody on our panel has kind of spoken to the fact that, we discussed earlier that there's not been incentivization historically for, really looking at patient wellness programs. Our physicians have never gotten paid to make sure that their patients are healthy. They have only gotten reimbursed when something went wrong. Same with our health systems and our hospitals. So as we're looking at creating that shift, I think from a consumer focus, if we could start looking and really supporting those programs that allow these different types of services to reward for those better healths and offer these services to keep us healthy, I think from the consumer, that only continues the momentum for value-based healthcare to grow, and once again helps with that reimbursement for our care providers so that they can get reimbursed more as preventative care than necessarily waiting until it's 2 a.m. and we have to drive to the emergency room.
healthcare creates this like emotional reaction. I may be stealing thunder from somebody else, but if you go, hey, I'm new to town, and I say I've got 3 kids, and if I need to find a pediatrician, how do I find that pediatrician? It's probably over a fence or at a mailbox, and it's hey, who do you go to? And that other parent is probably going to recommend the pediatrician they go to, because saying, it's just my kid, like fair to middling healthcare doesn't matter. And I also actually know the difference between a good pediatrician and a bad pediatrician. And I took my kid to a mediocre one. Like no one's ever done it, right? So how a person thinks about the person that's advising their family on healthcare, it's largely referrals with very little perspective on who's good at what they do. And I think trying to identify ways to find someone that's great at that and helping the patient find that service provider, that trusted advisor around your healthcare is it's really foreign concept. But we built Angie's List around this, right? And Yelp. There's in every other thing you can crowdsource ideas on who's good. The other thing is pretty much everybody knows how they feel about how good a pizza was. But having perspective on your relationship with your doctor for your conditions and how they manifest in you isn't that useful to the person next door who has different conditions with different needs, and they have different expectations because they've used another doctor. Normalizing how we perceive the quality of outcomes, some of the measures that Jenny started with, those are things that need to become far more streamlined and understood, where there's a common understanding of what 4 stars means or 5 stars means. There's certain things you can do in the surgical world. It's really hard to do that for PCPs. There's some stuff you can do with, primary care physicians. There's some things you can do around specialists. There's some things you can do about drugs. But guiding that patient to a really great provider is crazy hard. And some of it is quality metrics that everybody can agree on. But kind of educating folks on how to seek out high quality providers, it's a huge hurdle to get over. Jenny also used the word transparency. People having a reference price for what they buy and caring is crazy hard in healthcare. If someone could sort that out, the easiest way to solve for it, when you look at Jenny's slide, is the UK. You don't need to think about how much you pay, because we're going to pay it for you. And that's, as of today, not a great American solution, but it does create an issue. The user of the thing doesn't pay the majority of the bill. The person that pays the majority of the bill doesn't make use of the service directly, and they didn't perform the work. The person performing the work doesn't actually know how much the user should pay, would pay, or how much the payer pays. So that really bifurcated system makes it so that nobody has transparency to the other stakeholders the way any other thing happens, right? The manufacturer of the TV knows how much the retailer is selling it for, and the customer knows what they're buying and how they're getting it. Healthcare obfuscates every bit of that transaction. And I think that creates one of the biggest barriers, but opportunities for entrepreneurs and providers and payers and patients to try to figure out.
Robert, when in his earlier comments, mentioned something called a narrow network or a limited network, and Eric is kind of referencing that a little bit when he's talking about how do we ensure patients or members get to the right provider at the right place at the right time. In our language, we'd like to use the term the high quality network, narrow network, whatever the right word is. But the assumption there is that the primary care provider and the specialists are all on the same page and sharing information from one to the other, so that the primary care provider hears how the surgery went and knows that maybe the surgery didn't go as well as it should have gone, and that patient may stay an extra day in the hospital, and they're going to have to follow up on some kind of a complication that they weren't prepared for afterwards, instead of just showing up back at the primary care office a month later and not knowing that there was a blood clot, or something that went bad in the surgery. On the other hand, the primary care provider working with a high quality network, Eric, you mentioned spine surgery earlier. If you're working with a high quality network, that network hopefully has a spine wellness program, and they'll do therapy and other non-surgical interventions before we take the patient right to surgery. Because there's a whole lot of evidence that non-surgical interventions and surgical interventions have pretty similar outcomes 6 months and 1 year down the road. And let's see if we can keep a patient out of surgery before we rush them in and do a whole bunch of interventions that may or may not work.
Consumerism in the healthcare world is not going to be there until it's like walking into McDonald's and you can see the price of something and know what you're going to pay beforehand. I worked with a doctor yesterday who was going in for a service and wanted to know what they would have to pay beforehand. And it's a doctor, they're the ones that do these services every day. And I had to say, well, this is what your plan design is. This is what your deductible is. This is what your out-of-pocket is. But I couldn't tell them what the surgeon or the ambulatory center is going to charge, because there is no main source. There is no Amazon out there right now that provides that information. There are some entities out there that do aggregate some of this data and can give you some estimates beforehand. But really, for the employee or the patient to go through that extra bit of work when there isn't an incentive in there right now for them to go through those steps, you have to change the patient behavior, who already thinks, well, this cost me what my deductible is, or this is going to cost me what my out-of-pocket is, when the true cost of that is 10, 15 times that number. You need to give them an incentive to go do that research, and you need to make it easy for them, as easy as it is on Amazon. So if there's somebody out there right now looking for a way to improve the delivery system in healthcare and provide some transparency, that would be an area that I would suggest.
I am curious now. I think that those were each interesting takes on sort of the misalignment of incentives and what I've seen called the principal agent problem, where the person receiving care is not the person paying for it, right? So in my line of work, that can make it challenging to design technology products that sort of satisfy all of the stakeholders and solve real problems. I'm curious, maybe Eric, have you seen any software solutions or startups or anything like that have come in and helped bring new programs to the employers that you worked at to help advance value-based care?
Yeah. I would. This is a kind of a ripe area. There's a lot of startups that have a cool solution, and in many cases, it's because the person that got the wheels turning was a patient, and they said, "I'm not a doctor. I'm not a nurse. I'm not a pharmacist, but I deal with this condition every day. I work with this ecosystem of people that are experts, and this is awful. There has to be a better way." So let's pick on the condition of diabetes. There's probably, I'm going to say, a dozen different organizations that market themselves to large employers. In many cases, large and small employers. Many of them have a great reseller network through other vendors, right? So there may be smaller organizations that are making use of certain small, really cool tech solutions, but it's because it's white labeled underneath the pharmacy benefit manager that's bundled with the health insurer, right? They would never know it's the back end. But you pick on diabetes, and I mean, for the majority of folks who are managing that condition, they're taking a small needle to create blood to put it on what is essentially like the litmus strip that you used in junior biology, and then putting it in a device that gives them this arcane reading on how much sugar is in their blood, and then they understand how much is good or bad, and then they try to act based on that to try to regulate their blood sugar if there's an action they think they should take. I mean, they are now educating themselves to be a portion of endocrinologists to manage these conditions, and it's really, really hard. The steps of that, because now you're using things that you can deplete those testing strips, there's kind of a cottage industry of it now, because it turns out you deplete those, but you need more, and there's kind of a regular cadence of it. So there's a few Dollar Shave Clubs out there for testing strips. And those guys were like, well, wait a minute, why don't we just Appleize this group of things? So strips and lancets and glucometers, the device that reads that, they've become iPods. Apple did it. They said, well, I'll make my own proprietary device with my own proprietary music file typing with my own proprietary shop. And the reason that it works for Apple is, at least their old slogan was, it just works. So when you create customer-centric, user-designed solutions that make it easier to get stuff done well, removing barriers for patients to take care of themselves well and give them the support they need, it turns out they do it. The challenge is you then got to be able to identify, did I spend less on this cool solution than I would have otherwise if I didn't have it, and let the chips fall where they may? And maybe it's how much I paid for glucometers and strips and lancets, or maybe it's how many emergency visits I didn't have because that person didn't slip into a diabetic coma as they got behind the wheel of a car. Some of those solutions actually use cloud-based transmission of those telemonitoring results, so that if a person is in a dangerous spot, they get a phone call immediately from a qualified person to help them manage through the condition in real time. In all honesty, I've seen some of those programs that generate great value. Like, associates love it. I've had somebody almost break my hand when I walked into a store saying, if you're the guy that runs that, thank you, because I probably wouldn't be alive today to talk to you about it. However, those same things are very hard to show an ROI on. So in some of these conversations for payers and for other stakeholders, if you have to prove a definitive measurable ROI in healthcare, it's crazy hard. So for more progressive employers, it's what are the things I can do to generate value for my associates, make them productive, empowered, and capable. And as long as it's kind of a one-for-one swap on how much I'm paying for the stuff, it's worth it for the user experience.
And just to kind of tag on a little bit of what Eric mentioned on that patient-centered care, he talked about a lot of devices where it's really empowering the patients. A lot of what we find on success in these metrics is really creating a wellness program in which the patient helps decide what's the best program that's going to work for them. You can ship patients 2 cases of strips. You can give them a glucometer. You can give them fancy technology, but if you don't give them the education to use it or realize that they can make a change in their health condition, it does very little good. And so I love to hear, one of the things I was really excited that Eric was going to be on the panel is he gets it. He understands the fact that we really need to empower our employees to give them the tools necessary to where they can make an impact on their own healthcare.
Awesome. Thank you, Jenny. I think that is a good note for us to end on here. We're just about out of time. So thank you all. Thank you, Jenny, Robert, Matt, and Eric so much for this awesome discussion today. And thanks to our audience for joining us. And we hope you enjoy the rest of Boise Startup Week.